Should an AI company prescribe medications without physician involvement? Is transcatheter tricuspid valve replacement safe and effective? Can applying antibiotic powder to operative wounds prevent deep surgical site infections after tibial fracture? This and much more on today's JAMA Editor Summary. Hello and welcome to our listeners all around the world. Today is Friday, April 17th, 2026. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today, I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Hi, Preeti.
Hi, Linda. Let's start with the first research article, which is about tricuspid regurgitation. Traditionally, surgical repair for tricuspid regurgitation has been performed rarely, largely because the risks of an operation are too high for affected patients. Transcatheter tricuspid valve replacement is a newer, less invasive approach that's now FDA approved in the United States. Dr. Makar and colleagues published a cohort study from the National STS-ACC Transcatheter Valve Therapy Registry. The registry included all U.S. patients who underwent transcatheter tricuspid valve replacement from February 2024 to March 2025 at 82 centers. The primary outcomes were 30-day event rates, including all-cause death, stroke, bleeding, and heart failure-related hospitalizations, as well as reduction in tricuspid regurgitation and changes in health status. The authors reported that among 1,034 attempted procedures, a valve was successfully implanted in more than 98% of patients, and 30 days after the procedure, 97.7% of patients had mild or no residual regurgitation, meaning the valve was successfully fixed. All-cause death was 3%. Bleeding occurred in about 8%, and 16% of individuals had a new cardiac implantable electronic device. Investigators concluded that patients undergoing transcatheter tricuspid valve replacement experienced acceptable early safety, near elimination of tricuspid regurgitation, and significant symptomatic and health status improvements.
This strategy could be very helpful for patients who can't have traditional surgical repairs. Now let's turn to a common and challenging issue in orthopedic trauma surgery, preventing deep surgical site infections in patients with periarticular tibial fractures. These infections are associated with significant patient morbidity, prolonged recovery, and increased healthcare costs, making infection prevention a priority. The Major Extremity Trauma Research Consortium conducted the TOBRA trial, an open-label, assessor-masked, randomized clinical trial across 39 U.S. trauma centers. The investigators assessed more than 1,500 randomized participants undergoing definitive surgical fixation of periarticular tibial fractures to determine whether intrawound vancomycin powder with or without added tobramycin powder would reduce the risk of deep surgical site infection within 182 days, or about 6 months. The investigators reported that there was no significant difference in the primary outcome, with deep infections occurring in 7.4% of patients in the combination group and 6.6% in the vancomycin-only group. These findings suggest that vancomycin powder alone remains an effective standard without evidence to support routine use of tobramycin powder in this setting.
As an infectious disease specialist, I love the TOBRA trial. This is a difficult study to pull off logistically, and the results help inform the best approach for preventing deep surgical site infections with tibial fractures. Now let's discuss this week's research letters. In January 2023, based on growing evidence of safety and effectiveness, the FDA removed its requirement that Mifepristone for medication abortion be dispensed only in person at clinics or hospitals. This shift coincided with rising medication abortion rates, especially via telehealth, but the real-world pharmacy impact was unclear. Dr. Scannell and colleagues used national prescription data from January 2021 to August 2025, analyzing trends in Mifepristone use before and after the policy change. The study included more than 71,000 individuals with an average age of 28.6 years who filled about 80,000 prescriptions for Mifepristone through retail or mail-order pharmacies. The authors reported that after the FDA policy change, the average number of monthly users of Mifepristone increased from 18 to 2,731, with nearly 98% of prescriptions filled through mail-order pharmacies, concentrated in states where abortion is legal and telehealth is permitted. In contrast, in states where abortion is legal, with telehealth restrictions, 61% of Mifepristone users filled prescriptions at retail pharmacies.
And in another research letter, Dr. Basu and colleagues conducted a retrospective, repeated cross-sectional study using publicly available records from fiscal year 2004 through January 19, 2026, to evaluate mortality in U.S. Immigration and Customs Enforcement, or ICE, detention facilities. The analysis covers deaths occurring during active ICE custody, even if the deaths happened in hospitals. The authors identified 272 deaths in ICE detention during the study period. Over 90% of those who died were men, and the median age at death was 45 years. Mortality rate per 100,000 person years rose sharply to 47.5 in fiscal year 2025 and 88.9 in partial fiscal year 2026. Unclassified or undetermined causes of deaths were common in all periods, ranging from 18 to 60%. The authors recommend that more complete mortality surveillance that can be audited is needed for individuals in ICE detention facilities.
The editorial that accompanies this research letter by Drs. Heisler and Peeler offers helpful context. They point out that as ICE detention numbers increase, mortality rates are climbing fast, especially among those with complex health needs. They highlight weakened medical access, deteriorating facility conditions, and gaps in mental health support that create real risks, underscoring urgent calls for restored oversight and evidence-based humane care.
JAMA published some thought-provoking viewpoints this week. In their viewpoint, Drs. Aaron and Robertson explore Utah's first-of-its-kind partnership with an AI company that will prescribe medications without physician involvement. They explore whether AI can safely step into the prescriber's role and what this means for the legal, medical, and ethical foundations that govern our healthcare system. There's also a viewpoint about international drug pricing. Drs. Kang and DiStefano explore whether CMS's new GLOBE, GUARD, and GENEROUS models can cut federal spending without compromising patient access or innovation. Are these global benchmarks the answer, or will they invite complexities and unintended consequences? And Dr. Gottlieb takes aim at a familiar ritual in U.S. hospitals, mandatory annual training modules. In his viewpoint, he asks whether these repetitive requirements are actually improving patient care or just piling on administrative burden and lost clinician time.
And Linda, JAMA has some exciting news. Dr. Allison Wong and JAMA Editor-in-Chief, Dr. Kirsten Bibbins-Domingo, have an editorial that announces the creation of the JAMA Plus Trials Initiative. They explore the enduring importance and complexity of clinical trials and explain why, despite frustrating obstacles and unexpected results, we continue to rely on trials to shape and sometimes overturn our understanding of clinical care.
Dr. Wong, JAMA Associate Editor Dr. Greg Marcus, and JAMA Dermatology Associate Editor Dr. An Wen Chan start this conversation with a thoughtful editorial about the utility, barriers, and burdens of virtual and remotely conducted trials. Watch the associated video to hear JAMA Plus Trials Editor-in-Chief Dr. Allison Wong describe the challenges faced by clinical trialists and the need for new tools and strategies to help the field evolve.
Drs. Mager and McLean authored the latest JAMA review article on endometrial cancer, which accounts for 95% of uterine cancers. They summarize risk factors, clinical presentation, diagnosis, and other important information for clinicians. In the JAMA Clinical Reviews podcast, Dr. McLean joins JAMA Senior Editor Dr. Karen Lasser to discuss the current evidence about diagnosis and treatment of endometrial cancer. Let's hear a clip from their discussion.
So you're getting to my next question, which is, how is endometrial cancer diagnosed? So what we ultimately need is a biopsy of the lining of the endometrium, and this can be performed either in the office, and that's with a small suction curette. It's like a little straw, but even smaller than that, or in the operating room with what's called the dilation and curettage.
And which patients should have an ultrasound?
So in a postmenopausal patient, an ultrasound can be an initial test to help know whether there's concern for underlying endometrial cancer. And the historical threshold has been an endometrial thickness of 4 millimeters. We talked a little bit about the limitations in the setting of fibroids. And also there are other limitations, including premenopausal women in whom a ultrasound is not as helpful. And also, it's really important to say if any woman of any age has persistent bleeding, then they should really have a biopsy and not just rely on an ultrasound.
And the newest patient page is also on endometrial cancer and a helpful resource for patients. Finally, there's a clinical challenge by Dr. Bellman and colleagues. What's your diagnosis for fever, rash, and shortness of breath in a previously healthy adult?
And as always, there's a lot happening in health news. The JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
Well, that's a wrap for this week's JAMA Editor Summary. Thank you, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Stephens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, and thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.